Okay, so I thank everybody that's on the webinar already. We're just going to give another couple few minutes for the rest of the attendees to make it in. So just give it a few more minutes and we'll get started. Let's say at 4:05 PST and whatever that is where you are. Okay, well, again, for those of you that have already joined, thank you so much for joining me this evening and taking time out of your busy schedules. I can tell you that I just had a morning full of clinic and boogied back home as quickly as possible to do this webinar, and I'm sure the same can be said for most of you. So thanks for adding this to your busy schedules. I'm happy that you're interested in learning more about the Advanced Integrative Oncology Palliative Care course. Um, and this specific talk on what this course is really about. And this webinar's theme is mastering step-by-step protocols for common symptoms in cancer and chronic disease care. This is not just for cancer, this is for anybody with a serious illness. And by the end of this webinar, I think you're going to know what that means and why this course and these algorithms are so invaluable for both you as the clinician and your patients under your care. So let's see. There we go. All right. So this is the flow for today. So there's going to be a brief introduction. We're then going to go into two of the algorithms that make up the 26 algorithms that are in this course. I chose a couple of topics, not for any particular reason. So alopecia, it's the first in the alphabet in the course, and we chose ototoxicity, something that people don't know much about or maybe know a little bit about. But these are just to whet the appetite so you can get an idea of what this course provides. We're then going to talk a little bit about this tsunami of palliative care patients, and this is going to be very important for all of you to know. This is not just about cancer, as I said. This is about anybody with a serious illness and the palliation of people living with a chronic disease that they will indeed have for the rest of their lives. The uh, the necessity of us all to do a better job of improving the quality of life of these people and managing all of the little fires that come about during the course of their illness. Um, this is going to be a part of the talk. We're going to talk about our solution at the Integrative Oncology Institute and what it is that we are doing to help manage this and to prepare doctors, naturopathic physicians, medical doctors, osteopaths, nurses, pharmacists, all of the healthcare providers that are involved in the care of a serious illness and the patients dealing with them. We're going to share what our solution is. And then I'm going to open it up to some questions, and hopefully I'm able to answer most, if not all, the questions, and that'll be the end of this webinar. It is only for an hour, so I want to make sure that we get those questions answered. So I'm going to roll through this relatively quickly. So the Integrative Oncology Institute, of which I'm the founder, this was formed because of what I see as a need. There is a need, a very, very large need for specialized education in integrative oncology. And um, for those of you that are in the field, you know that's true. There's not too many textbooks, there's not too many conferences. There's not too many residency opportunities, fellowship opportunities. A lot of the learning is on your own. And as somebody that's been at this for 25 years, I am grossly aware of how much of the knowledge gathering has to be done on our own. So this really was born out of what I see as a need. Integrative oncology education is crucial for improving patient outcomes and bridging the gap between conventional oncology care, conventional medicine, and complementary and integrative medicine oncology care that provided by those in the community, from naturopathic physicians to integrative physicians of every stripe. We know that the vast majority of people diagnosed with a serious illness, including cancer, turn to CIM as a rule. You know, most studies show somewhere between 60 and 80% of people diagnosed with a malignancy or other serious illnesses, they're looking for what else they can do. So a little bit about me. For those of you that don't know me, hi, it's nice to meet you. My name is Gurdev Parmar. I'm an ND and since 2000, and a FABNO since the very first year FABNO was a thing, which was 2007, the first FABNO in Canada. And my wife and I, my partner, Karen Parmar, and I co-founded the Integrated Health Clinics, the first one in 2000. We have a second clinic here in the Lower Mainland of British Columbia. I'm the lead author and editor-in-chief of the textbook of naturopathic oncology, which looks something like this. You can see I use mine. I'm the current professor of oncology at the Canadian College of Naturopathic Medicine Boucher campus. I'm very pleased and excited to be presenting on the integrative palliative care approach at the upcoming McGill University International Palliative Care Congress. in October. There's going to be somewhere between 1,500 to 2,000 attendees from around the world, all about palliative care. And I don't know that naturopathic oncologist or ND has presented on integrate or in an integrative or a naturopathic approach to palliative care. So I'm very excited to get that in front of people. And I'm currently licensed in both British Columbia and Washington State. So there's a little snapshot about me and why I might have some information that is interesting. So let's look at the first algorithm. Um, this is not available on its own. This is only available to those people that register for the course, but this is what all the students receive, an algorithm book. And inside of that algorithm book, there are complete algorithms for 26 most common symptoms that we see. And as you can see, this is just a broad sweep. This is the tree diagram. For each of the symptoms, there will be a tree diagram such as this. And you can see that at the top, there are some preventative or low-lying fruit lifestyle, nutraceutical or dietary recommendations on best preventive practices. We then, for each one of these 26 symptoms, break it down into grade. And then depending on the grade, what treatments should be considered. And so that's a general sort of overview of the entire algorithm, and that's just the tree diagram piece. But for each of the symptoms in this course and in this book, first of all, let me say the course is made up of 28 lectures. Each one of those lectures is a PowerPoint presentation with video and audio, and the students receive all of those PowerPoint presentations. They receive all the videos. They receive transcriptions of each of those lectures, and the transcripts have all of the references. There are reference documents for each one of these modules with all of the treatments and all of the references for those treatments, and they're all there in a way that's easy for you to use, share with other doctors, share with your patients, and they can see that what you're doing is based on evidence. And of course, our faculty includes radiation oncologists, medical oncologists, naturopathic oncologists, palliative care physicians, and they've had an opportunity to share what they believe from their own perspective, what the best approach is, and which treatments that may not have a great deal of evidence are the ones that after 10, 20, 30 years of being in this field, clinically these work. So there's evidence, and there's also really good anecdotal, experiential recommendations as well. So for each one of the symptoms, there's this sort of algorithm. So a symptom assessment, how to do a proper history taking, what questions to ask. And each one of these questions is going to help dictate what the treatment is going to be. So rather than you having to keep this all in your head, like, oh yeah, I remember for alopecia, I have to ask these questions. No, it's there. You can very easily consult your book, consult your notes, consult what you have on your computer right there with the patient, and go through the symptom assessment, the physical examination assessment, and then as a naturopathic oncologist, as an integrative physician, you're going to be interested not only in, oh, so your hair loss started with the onset of chemotherapy or with radiotherapy or after your surgery, all of these sorts of things that most people will know about, but you're also possibly going to be interested in what's your hematology look like, what your iron studies look like, how's your thyroid functioning, B12 levels, all of these other clinical issues that may be contributing that and those are a part of the assessment as well. And then what is the grading scales? One of the reasons why we chose alopecia and ototoxicity is that their grading scales are quite simple. And so it wouldn't take, an hour and a half to 2 hours to just go through one of these. It's going to be rather brief. So for alopecia, if it's grade 1, less than 50% hair loss. If it's grade 2, it's 50% or greater hair loss. And it's visible or it's not. And then, of course, what you can do to possibly prevent this from happening to begin with. And of course, as I mentioned, each of these recommendations is referenced. So you can see that for the alopecia module, references 2 to 11 are included here. So these are some of the best evidence informed preventative recommendations or nutritional recommendations for alopecia. And we recommend this to anybody that is going to be using a treatment which is likely to cause alopecia. And for those patients that are very motivated to not lose their hair, and they are taking something like a taxane, which is very likely to cause alopecia, in many cases severe, grade 2, or even universalis. We also share the evidence for cryotherapy, which can be used in addition to making sure you have adequate B vitamins and zinc and iron and selenium and essential fatty acids and a minimum of 0.6 to 1.2 grams per kilogram of body weight of protein per day. And in some cases, it's more like 1 to 2 grams per kilogram per day. So there's some nice preventative strategies, but if the person does indeed experience hair loss in grade 1 or grade 2, this is what we recommend. So if it's less than 50% hair loss, and the patient does not feel motivated to do too much, they want to just know what they can do. It's not too bad. They want to prevent it from getting worse. These are the recommendations that we would make. If you listen to the lectures, here it's just listed. But if you listen to the lectures, myself and my colleague, Dr. Kevin Slater, who's a palliative care doctor, who's on faculty at the Integrative Oncology Institute and also an associate of mine at Integrated Health Clinic, the two of us will review 2 cases at the end of each one of these modules, real life clinical cases. Each and every one of these symptoms in a couple of cases in our clinic. So it's not necessarily the case that you would put a person who wants to prevent alopecia or who is dealing with grade 1 alopecia on each and every one of these supplements. It might be more related to your clinical knowledge and clinical quiver. You have a patient that has heavy menses, a long-standing history of iron deficiency, microcytic hypochromic anemia. Iron's probably going to be high on your list. A patient's told you, oh, I've already been using biotin and it's not really helping. Well, you're not really going to recommend that. So, using a person, let's say, is dealing with some level of dysgeusia, their taste buds have changed, or they don't taste well at all. You might be more motivated to recommend zinc in that case of alopecia because there's another symptom there that might be pointing to a deficiency. So, using your own best clinical experience and quiver you can choose which or all of these supplements that you might recommend to that particular patient. If it improves, great. If it doesn't improve, and now they're heading into grade 2, these are the other considerations you might have for your patient. And this is the Integrative Oncology Institute, and this is all about integrative approach. So platelet-rich plasma, PRP, is discussed, and what are the potential benefits of this, and what kind of experience does a person have with this? Minoxidil, 2 to 5%. We typically only recommend 5% in our practice because we have found that 2 is not really used. All of these clinical pearls that I'm telling you right now that you will not read when you read this is just tell you exactly what to do. But these clinical pearls are all in the lectures, and you have to sit through all of these lectures to get those pearls of what in my list or Dr. Slater's list or our faculty's list would be highest priority and down. So that's what the algorithm looks like. Now let's take a look at ototoxicity, another one of the algorithms in the book. Ototoxicity, the definition, damage to the ear caused by chemotherapeutic agents, most commonly cisplatin and carboplatin, to tinnitus and to hearing loss. And what's graded in the realm of ototoxicity is the tinnitus and the hearing loss. So most of you know what tinnitus is, most of you know what hearing loss is, but you may not know what the grades are. And this will let you know what those grades are. Again, we will go through a symptom assessment when interesting. Each of these related symptoms will help lead you into understanding better what is underlying this and what treatment options are most beneficial for that patient. And as you'll learn if you take this course, we always try to use treatments that press more than one button at a time. So if one agent looks like it's going to improve 2, 3, 4 different things in a patient, that makes sense. I'll give you an example. I had a patient come in today who has a mesothelioma, and she's severely fatigued. She has nausea. She has dysgeusia, change to her taste buds. She has anorexia, severe anorexia with no appetite whatsoever. And she came in having seen a medical oncologist and her family physician, and she had been given 2 medications already for the nausea, both of which were making other things a little worse, including her fatigue. It was making her sedated, which was worsening that. And it wasn't really improving anything else, and nor was it really helping for the nausea. So we talked about using low-dose dexamethasone today as a treatment, one treatment, low dose, which will address the fatigue, the nausea, the anorexia, and the dysgeusia. And so this is how we like to use things like this. And of course, you better believe that that patient was also recommended all of the other things that we recommend naturopathically or integratively to help manage that symptom as well. But that's an example of the type of clinical pearls you're going to learn if you take a course like this. And let me say that if you're not a prescriber, in British Columbia, we're prescribers. Many of our students are not prescribers. They are in jurisdictions where they cannot. And it's still valuable for them to know what the algorithm should look like. What is my playground? How far can I take this before I need to refer to the family physician, the primary care provider, or whoever, the medical oncologist, radiation, whoever it is, for the next step of treatment? Because I did everything that I can do, and now it has to move into this. That, in my opinion, that's invaluable. Again, for ototoxicity, just like the alopecia algorithm, there's recommendations for the physical assessment. And then there's the grading scales, ototoxicity grading scales. There's those for those grading scales that are easy for us to use in practice, where we don't have um, audiologists and audiograms and this technical information. But many of our patients with ototoxicity have gone for that type of testing, and depending on what the results are, you can dictate which grade they currently belong in. I mentioned earlier in the ototoxicity algorithm that carboplatin and cisplatin are the two most common reasons for ototoxicity in the cancer patient from a chemotherapeutic agent. And one of the only things that's been shown to help prevent the severity of the ototoxicity or ototoxicity to occur at all is adequate hydration. And it essentially dilutes the drug in the blood. Therefore, it's not as concentrated when it's hitting the nerves, and therefore it's decreasing neurotoxicity, not just in the ears, but everywhere in the body. And so that's a good preventative. And then, of course, we recommend that if a person is going to be using cisplatin or carboplatin, and and you're concerned about ototoxicity, or they are, that you get the baseline testing done, and then it's repeated to see where they fit in this grading scale. And then exactly what do we recommend for grade 1, grade 2, grade 3, and lastly, grade 4 ototoxicity. Again, it's all there for you. For those of you that are in this webinar, the gems are there, and those protocols are ready to go. So again, those are two of the algorithms inside of the 26 algorithm book. And as mentioned, each one of these includes a symptom overview, an actual algorithm, and a tree diagram. And the algorithm includes definition, symptom assessment, physical assessment, grading scales, and then, of course, the naturopathic and conventional treatments for each and every one of those. So what do I mean by this upcoming tsunami of palliative care patients? It's already at the place where there is a gross there are not enough palliative care physicians out there, and the population of patients that need them is at an all-time high. A part of the reason is because of a broader definition of what a serious illness is. It used to be the case that palliative care was only for end-of-life cancer patients. And that is not what palliative care is. Palliative care should be started at the time a person is diagnosed with a serious illness that they are going to have for the rest of their life. It's an incurable, lifelong condition that has all sorts of potential side effects or issues or symptoms that are going to happen through the course of that person's life. They're just expectations. So the definition of palliative care has greatly expanded to include anybody with a serious illness, not just cancer. And the amount of people that currently need this type of care has already outstripped the capacity of current healthcare systems, not just in Canada, not just in the United States, but everywhere in the world. And the largest reason is there's a severe shortage of people trained in this. So as mentioned, the expanded definition of a serious illness, the 4th edition of the National Consensus Project for Quality Palliative Care Clinical Practice Guidelines defines a serious illness as, and I quote, a health condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life or excessively strains their caregiver. That's a broad definition. So from very end stage cancer patients to this, any health condition with a high risk of mortality that negatively impacts a person's quality of life. So this now includes later stages or end stage heart disease, lung disease, kidney disease, liver disease, autoimmune conditions. Many conditions are now in this category. And we have an aging population, and partly because medicine is so much better, but also because that's just what's happening to the population. There's a demographic shift. And as people age, these chronic illnesses become more likely. So we are at a state right now where palliative care is critically needed. And I will propose to each and every one of you that are attending, and I'm so glad there's so many of you, that you should be a part of this answer. Uh, there are primary palliative care doctors, which is what I am, and then there are specialist palliative care doctors like my colleague Kevin Slater. A palliative care, primary palliative care, or generalist palliative care is delivered by any healthcare professional who is not a specialist. So this includes us, primary care clinicians, disease-oriented specialists, so oncologists, cardiologists, respirologists, nephrologists, nurses, social workers, pharmacists, chaplains, all the people that are not the specialist palliative care providers, they're all generalist palliative care providers. And we need more people to step up and fill the cracks and provide the care that these people need. And we need it now. And for those of you that are on this webinar right now, I have a sense that you are already in the integrative or naturopathic fields. And we are very well suited to be providing this type of care. As it stands, integrative naturopathic physicians were trained to combine modern medical science with traditional practices, pharmacology, nutrition, lifestyle, botanicals, nutraceuticals, etc. And as a profession, both for naturopathic physicians, integrative physicians, MDs, DOs, etc., PhDs, this palliative care is a team game. I think we are all in a team game too. I don't think, I hope, that most of us don't think that we can do everything for everybody, and that there's a time and there's a place, and we are critical components of that team. So to address this crisis, we need training, we need education, and we need it now. We need some comprehensive training programs, some CE, to help people understand what the interdisciplinary approach is. So this brings us to the AIOPCC, the Advanced Integrative Oncology Palliative Care course. So what is this? So this is the first course on integrative approach to palliative care and oncology, period. We don't know of another one. It integrates the evidence-based and anecdotal naturopathic treatments with the current standard of care. It provides modules on all the most common cancer-related symptoms. I have to get the door. My dog is squeaking. My apologies. My beautiful dog, Lou, had to use the loo. And he's so smart and he let me know that, and I'm happy. I'm happy about that. Otherwise, I'd be doing something else. So where was I? So this is the first course that I know of in the integrative palliative field, where we train our attendees to integrate naturopathic with standard of care, and we give the keys to the kingdom for all of that. There are modules on the most common symptoms. I think these are statistically the 26 most common symptoms that we see in the palliative or chronic disease management fields. And I think if you all look at the list, you'll say, yeah, I spend 80% of my day doing that kind of stuff for people. Um, this is an incredible educational experience for oncology health professionals, as well as those that just manage chronic disease, period. Um, it's really about improving our patients' quality of life, and the quality of the care that we can deliver. And I think this is a must for any physician seeing cancer patients. And if your practice is like mine, the majority of people that we see have metastatic disease and not necessarily curable intent treatment. Their treatments are palliative intent. It's to improve their overall survival. And I will propose one of our most important jobs is to improve their quality of life, as well as their overall survival. So who's it for? As mentioned, all of those providers that are involved in the care of a person living with a serious illness, including cancer. This is our major course contributors for the AIOPCC, and some absolute superstars here on this list. People with a lot of experience, people with hospital experience, community experienced, naturopathic, radiation, medical oncology, palliative care. It's a good representation across all of those fields. What will you learn? I gave you a very brief look at the algorithms, but if you make it into this course and you get into each one of these lectures, you're going to understand these symptoms from a pathophysiological level like you have never, um, and how to diagnose, how to assess, how to grade all of these symptoms, how to apply a model of treatment to manage each of these that is algorithmic and logical and reproducible. I don't know about you guys, but the most stressful thing day to day in clinic is something's presented to you and you're just having to try to remember everything that you need to manage it. Well, I'm in my 50s now and I'm done with that. I really don't need that kind of day-to-day stress. It's really nice to have um, these tools at your fingertips so then you can navigate it and do truly individualized, truly naturopathic, integrative, individualized approach for each one of these patients without having to be responsible for just remembering everything off the top of your head. Giving strategies to improve quality of life without interfering with any disease-related treatments. An algorithmic approach to the utility of all of our clinical tools. And then at the end of each one of these algorithms, as I said, we apply what is learned through the didactic portion of the module into two real life cases that we talk about from the beginning to the end. So this is the modules again. You can see what is in it. So the first two, advanced integrative palliative care, it's an introduction to what palliative care is and what the advanced integrative palliative care approach looks like, what documents you need, what questions you need to ask, uh, power of attorney, uh, all of these very important conversations to have with the patient that is dealing with a serious illness. And you can be involved. And, as an integrative provider, as a naturopathic provider, your role can become very, very fulfilling when you're practicing in a collaborative team approach where you're communicating with the rest of the team. And I, I will say, as a naturopathic physician of 25 years in the field, I have found palliative care to be the most open, um, accommodating, transparent, collaborative field in medicine. It's really a part of the imbigraph of palliative care that it's a team game and not one person can do it all. And at the end of the day, the team has to work together for the best care of the patient and their caregivers. And they're the ones that dictate what they need. And I think naturopathic physicians are in such a good position. So some practical information about the course. When you register for the course, all the content is released, including the algorithm book. Each module varies in length, but on average, they're going to take about 1.5 to 2 hours each. You have access to the course for 18 months. And as mentioned earlier, each module has its handouts, such as the transcripts of the lectures, the reference lists, etc. At the end of each module, there's a self-assessment, there's 2 clinical cases, and you will be asked to create a treatment plan before you listen to what Kev and I have to say about it. And these case reports will not be a part of your grading, but please don't let that mean you shouldn't take these seriously and do them on your own and really test yourself and your knowledge, and then listen to Kev and I go through the cases ourselves. Uh, this is what's actually needed for testing. Every module has a 10 to 20 test question at the end. These are multiple choice to evaluate what you have learned. You must score 100% on each test to pass. You can retake the test as many times as you need to get that 100% score. And then once you've passed all of the tests, you can get this certificate of completion and the coveted 50 CE credits that come along with this course. This course will provide approximately 50 CE credits. It is 50 CE credits. CNPBC, the Ontario CONO, and AANP. And we do have a doctor from Oregon taking the course now, and we are getting Oregon. We are now in the process of getting Oregon certification. And I want to mention this. We are very, very close to getting ACME accreditation, ACCME. So MDs, DOs, nurses, all the other allied health professionals will also be able to claim CE credit. So that's been a long process, a long and arduous and expensive process, and we are just about there. I wanted it to be done, and I wanted to be able to say that we have that today, but unfortunately, it looks like it's going to be a bit delayed. So when I have another webinar in a month, I will be able to say that. So these are the current CE approvals. You can see CMPBC, AANP, and they all are 50 total, depending on the category, etc. So there are 2 course options. One is the essential, one is the premium. The premium, the one thing that the premium provides is a monthly live Q&A with Dr. Slater and I. So the students that register for the premium once a month for a couple of hours, they get Kevin and I, Dr. Slater and I, on a webinar, and they can go through their own clinical cases from their own clinics and walk through them with us. These are the course price plans, the essential and the premium. And we just completed this past week. We did not have a payment plan originally, but we have worked hard to create a payment plan, and you can see what it is there. There's an initial payment and then 6 consecutive payments for both the essential and the premium courses. And if you do it in the phased approach, the content is drip. 4 modules every 4 weeks rather than you get everything up front. And yeah, and then of course, so those are the course price plans. And this is how to sign up for the course if you decided to do it. You go to the integrative website and you can click on the course on the top menu. And that is it. Yes, it is. So please feel free to ask any questions you may have through the chat box. And let's see if I can do something else here to allow questions to be asked as well. Chat. So, hmm. Hmm. Well, how do I let you talk? Okay, there we go. Ah, you're welcome. So the first question, do you offer pricing in Canadian for us Canadians? No, I'm a Canadian too. Oh, that's good. I answered all the questions there. My pleasure. Thank you. Any other questions at the moment? I have a question. I don't know how you're going to answer this, but I would imagine that each of you that are on this webinar right now, you feel that you need a little bit more clinical information on the palliative care approach. Um, and the management of people with chronic illness. Ooh. Um, See, so this now I'm getting a couple of questions, but they're really specific, and these are the sorts of questions that I think we would be able to do a really good job of answering in our monthly Q&A for the people that do um, the full course. So, for example, is there any way you could share a sneak peek at what you do for rectal pain for a person dealing with colorectal cancer, for example? And I want you to know that, and it's an anonymous attendee, so I can't uh, say what your name is. Um, what I can say about that is the pain algorithm and the pain lecture, it actually is the longest lecture in this course. Um, it's complicated. There's pain is many things. It can be systemic. It can be pain just in the mouth. It can be pain like rectal pain. And of course, there are treatments that we would use for something where there's just pain in the rectum, for example, instead of pain like musculoskeletal pain in every joint of the body, where you would use something oral and systemic. Um, Without knowing anything about this case, without knowing anything about fissures and hemorrhoids and the location of the tumor, um, without knowing any of the clinical information, it makes it really difficult to answer this. But one thing that I will say is that if there is just rectal pain and it's by the verge or in the end of the rectum, that I would be motivated to use a local treatment on that. And I typically make compounds that are part naturopathic and part pharmaceutical for that type of pain, where I am using things such as aloe, um, glutamine, um, vitamin E, uh, and then possibly an NSAID, um, uh, and possibly some numbing anesthetic and something like that. And there are some standard uh, compounds that are provided in the course. Um, and these are compounds that we've developed over, 25 years or so, like for mouth pain, something like a lollipop or a swish and spit, or a swish and swallow, a slurry. For rectal pain, like I said, this sort of ointment. For topical pain, if it's just in one location, instead of that person having to take drugs that are systemically absorbed, they can instead use something topical just in that region. Um, and there's something to be said about Dr. Slater, 30 years of experience, and me, 25, and what it is that we do at this point. And bypassing all of the trials and tribulations and the trial by error or trial by fire. Um, there are currently no scholarship opportunities available for this course. Um, any other questions? Still have about 5 minutes left here, so I want to make sure that I'm not leaving until the time is done. So if there are any other questions, I can see there's still quite a few people here. You know what I'd like to know? I'd like to know, for the people that are still on this talk, uh, what symptoms did we provide algorithms for all of those symptoms that you yourself think are the most common symptoms that you see day to day in your practices? Oh, that's good. Thank you. I think so too. I think we hit the most important ones. Yeah, me too, Lisa. So all of you are on a mailing list, because for you to have been included for this webinar, you're on a mailing list. So I will put this out. For any of you that have any questions that I didn't address here, or you're too shy to ask right now, um, reach out to the Integrative Oncology Institute and through that email, um, and somebody will get back to you with an answer.